I'm just going to talk to you about some of the initiatives that we've got going here at King's College in chronic rejection, two of which are randomized controlled clinical trials, which I'll define and just update you on. One of which is a purely clinical initiative called the Optimising Transplant Survival Clinic. It could have been called the Chronic Rejection Clinic, but that wasn't as patient-friendly as we wanted to make it. We wanted to give this a positive slant. And I'm just going to talk to you about this. We've been trying to do this now for 12 months. It's in a little bit of a hiatus at the moment because we've come across significant issues relating to identifying patients and what to do with them. But our aim here was to try and identify transplant patients with or at risk of, we call it premature graft failure as opposed to late graft failure, trying to put the emphasis on the lifespan of the recipient rather than the lifespan of the graft, because the important point here is that transplants don't last for as long as the natural lifespan of the recipient. And ideally, we want to change that so that you get a transplant at whatever age and it takes you through to the end of your natural life. That's our ambition. It's very bold and it's very ambitious, but we've got to start somewhere. So our ambition in this clinical initiative is to provide a diagnosis in all these patients who seem to have transplant dysfunction or are at risk of transplant dysfunction, and then to provide tailored care based on standardized treatment protocols for all patients, and to try and stabilize graft function, minimize proteinuria, and reduce graft failure rates compared to present rates. I think everybody involved in clinical renal transplantation has these kind of targets. What we're trying to do here is give it a structure so that we can pick up patients and treat them in a formal way. And we want to ally this to some academic aims, which is to enroll all the patients into observational studies and then into therapeutic trials of novel treatments, and use the patient base to provide mechanistic and, insights and therapeutic interventions that we can hopefully try and develop in-house, and develop surrogate biomarkers for long-term outcomes. And we have got an observational study going. I'm not going to say any more about it. It's called Optimal, that is allied to this clinic. So our criteria for including patients, and this is where we've come across significant issues, is how do you identify patients at risk or patients suffering transplant dysfunction? It is incredibly difficult. It is incredibly difficult unless you've got some automated tools to help you. I'm going to talk about a trial in a second called Outsmart, where we're using the presence of HLA antibodies to identify patients who are at risk of early graft or premature graft failure. Here what we were trying to do was try and identify patients who had visually unrecognized long-term trends in their creatinine or proteinuria, and we're using a cutoff of 50. So we developed this automated tool which imported all creatinines on everybody from 1 year post-transplantation into an Excel spreadsheet, automatically drew 1/, creatinine plots, and then worked out the regression analyses of the trends in those creatinines over time. We got funding from the Kidney Patients Association for an administrator to do all this and collect data, and we went live August last year, and we identified 589 of our just over 1,000 patients who met the criteria that we'd set up for this automated tool, which was essentially to have linear regression analyses parameters with a rough fit, really, but this is acceptable for clinical, and a significant change in their creatinines. And 231 with a PCR above 50. Now, this was a significant number of patients that we hadn't anticipated, and the problem we've had is that we've had to then go through 2 additional manual screening assessments, which is very, very time-consuming and laborious. And we actually managed to whittle down the 589 to only 111 who actually had significant trends in their creatinine. So at the moment, we're on hold trying to refine this screening tool, and this was a massive effort. We started trying to recruit all these in August last year, and by our first audit, which we did in April, we'd only got 70. So actually picking up these people when they come to clinic was also quite difficult. Now, of the 70 we picked up, we'd already picked up 46 of them just on routine clinical assessments. So 46 of them had already been identified as having problems with their transplants, and those 46 have been biopsied within the last year or so, and it was in the remaining 24 that we focused on, and 13 of those have been biopsied by April. Now, these 24 that were remaining that hadn't been picked up by the clinicians had long-term trends in their creatinine that were really difficult to spot just by going back and looking at their creatinines. But when you plotted them on a 1/, creatinine plot and did the analyses, there were significant trends that came out.